Hello, good evening, viewers, and welcome to your favorite show, Ask Dr. Saw. Well, tonight, before we go on, we want to say welcome to the new viewers. We were seeing from the chats that we have some new viewers, and thank you for joining us. We hope that you find the show interesting and, as everyone say, very informative and educational. I'm your host, Akash Prasad, and this show is made possible by the Break News and the Guidance Critic platform, but more so because of the man himself, why the show is named as Dr. Saw, who's in England and this evening joining us. Dr. Saw, good evening.
Good evening, Akash, and good evening to the viewers.
Wonderful. Viewers, this evening we have a few questions from last week we're gonna be touching on. And I want to encourage you to send in your questions to us, even if it's not related to tonight's topic. So tonight's topic is hemorrhoids, or as some people will call it piles, right? We've all heard stories about that. So tonight, Dr. Saw will be talking about that. I have a few questions I'll be asking, but Dr. Saw, before I ask you what hemorrhoids and or piles really is, let me tell you as a I always share my own experience. I remember
Indeed, of course.
as a kid growing up, what I used to hear is that do not wear wet clothes, you'll get pile. Do not wear wet clothes, you'll get pile. So sometime later down in the show, maybe you can say
Shed
whether
some
that
light
myth
on that.
has any bearing or not. But first, this subject, it seems as if when I looked at it, it seems as if it affects a lot of people. So I want to ask you, what are hemorrhoids, or what we commonly call here in
Sure.
Ghana piles?
Yes, indeed. So, yeah, it's a good topic in that, of course, lots of people are affected, and I think it is estimated the adult population about 11% of people affected. So, we look at 1 in 10 people affected. Not everyone presents to the doctor, but of course, thankfully, most of them resolve on its own. However, the definition. So hemorrhoids or piles, they're swollen blood vessel in the lower rectum or the anal canal. So, at the end of the back passage, we call it, it's the anus, the lower end, the outer bit is called the anus, and that's like 3 to 4 centimeter long, right? And above that, you have the rectum and then large intestine. Now, what causes? So it's swollen blood vessel, and the makeup of that anal canal, it has got rich tissue, rich in blood supply, right? And
Okay.
we call them anal, and they have anal cushions. So they form like 3 anal cushions. So these are tissue with lots of blood supply in them, right? And they are positioned at, if you were to look at the anal canal as a opening, like a round opening, if you were to sit, lie on your back and open your legs, and then you look at you look at it as an opening. At the 3 o'clock position, there's a cushion, a rich tissue with blood supply. We call that an anal cushion. At the 7 o'clock position, there's another anal cushion. And at the 11 o'clock position, there's another anal cushions. Now, usually when you have piles, the blood vessels are engorged and they are swollen, but it bulges out at these cushion levels. So
Okay.
when we describe, if you go and examine somebody and you see piles coming out, you can say at 3 o'clock position, at 7 o'clock
Oh,
position, at 11 o'clock position, you can see that. This is just a little bit of a technicality, but I'm just
wow,
trying to
man.
explain that if
Yeah.
you were to just dissect the
Mm-hmm.
deeper cause, so people think it's just the blood vessel pushing out. But it's really not the blood vessel alone pushing out, it's the tissue around the blood vessel pushing out. So when you look at it, it doesn't look like a vein or an artery or a blood vessel. It looked like a tissue, like, a bit of skin or swollen tissue, redness or whatever. So that is
Right.
your
So that, well, that
definition of
but that'll
piles.
bring me to the next question, because you talk about it. I mean, what causes pile? But here's what my next question is: what causes this whole inflammation? What causes this whole
Area to be
this blood
swollen.
vessel? Yes, yeah. I mean, because
Yes.
that leads to what we're talking
Of
about tonight.
course, absolutely. So there are lots of theories. There isn't I mean, we can't pinpoint exactly that, okay, there's one cause for piles. So the theory is that there is high pressure in the anal canal. And I'll tell you some of the causes for high pressure. So there's high pressure in the anal canal, and the anal sphincter is tight. So the opening is tight, it causes high pressure and it causes protrusion, swollen blood vessels. Now, there are many reasons why the pressure can be high. So people who are constipated, for instance, the pressure is high. So if your diet is not like there's not enough fiber in your diet, yeah, processed food, usually they blame that on high pressure in the anal canal. Constipation, straining, coughing is a form of straining, and also the attributed blood vessel congestion. So we call that venous congestion. So when women, for instance, in pregnancy, 1/3 of women would probably have piles as well. It flares up during pregnancy because there's pressure in the blood vessel by congestion. We call that venous congestion because you have the baby pressing on the big flow of blood to go back to the heart, so the aorta, and you can have congestion of the veins. There are times when some patients have congestion in the, we call a portal hypertension. The blood flow to the liver it gets congested. So if you have liver failure, things like that, it can cause congestion there and it backflow into the hemorrhoids, and you can have piles as a result of that congestion. So anything that causes congestion, high pressure, straining, high intra-abdominal pressure, it can cause increased swollen blood vessels, and then after a while they protrude out.
Wow. So are there different types? Does it present differently? Are there different types of hemorrhoids?
Indeed, of course. So before I go on to show you the different types, I just want to share an image just for patients to understand. So if
Go
I
right
just
ahead.
share something here, I just want to share this. So this is a Google image. I just Googled this,
Uh-huh.
and you see the anal canal, this lower bit here,
Right.
um, is the anal canal. So, and this the blood vessel, internal hemorrhoids. So I was come to internal and external hemorrhoids. That's internal, and there's one at the bottom here. I don't know how could, yeah. Fine. Okay, cool. We can see this. This is
Yeah.
internal, it's higher up, and this is lower down. This is what we call external. So data piles are divided into internal and external. And the upper part of the canal is where you have the internal hemorrhoids, so the blood vessels there are swollen. And then on the lower third or the lower canal, you have the external pile. So they call it internal and external. The thing about the internal piles, it is covered by mucosa. Mucosa would be that, like in your eye, that is called mucosa, right? And then you have skin on the outside here. The external piles, it is very sensitive. It's covered by skin. So skin
Okay.
has got lots of pain receptors, whereas the mucosa itself doesn't have pain receptors to give you so much pain. So internal piles are generally not as painful unless there is a complication than external piles. So external piles are the one that is lower down into the canal. Sometimes you look at the anus and you can see the external piles while the
Oh,
internal one's
right,
inside.
right.
But
Yes.
so you have internal and external, but also the internal has got grades. They have grade 1, 2, 3, and 4. So this pile, for instance, you see it here, it doesn't protrude out, is inside. So if it's inside and it stays inside, we call it grade 1. If it bulges out and then it goes in back on its own, we call it grade 2. If it bulges out and we have to push it up, it doesn't go back by itself, we have to push it up, that's called grade 3. And if it bulges out and it cannot go up back, we call the grade 4. Now, so they have internal, external, and they have,
Mm-hmm.
so internal is higher up, external is lower down in the canal, and then they have grade 1, 2, 3, 4. So that's your different types. So I'll just take this off and
Okay.
share screen. Yeah.
Wow. So it's more it's more complex than I even
Then
imagined.
that's correct. It's not just, I
Yeah,
mean, yes, lots of people think it's a simple swollen vessel and that's it.
yeah. I mean, looking at that image there, there's so much more that's happening there than literally what meets the eye,
Yes, correct,
right?
indeed. Of
Yeah.
course.
So how do you know if you have it though? I mean, are there signs and
So
symptoms?
absolutely. So classically, when patients say I have piles, lots of people, the first thing they will come, they would either feel a lump in their anus or the back passage, they will feel a lump, or they will say, I've seen blood in the toilet. Or when they wipe themselves, they see blood. Or they would have pain. So the symptoms would be, how do you know you get it? You feel a lump at your anus. It can be with or without pain. And usually when you strain, you see blood. So they will come classically with a history. Doctor, I strained at the toilet today and I saw some blood in the toilet pan and I felt a lump in my back passage. So that's your clear-cut history. If you see that in a young patient or you heard that from a young patient, you can almost say, fine, I don't need to worry. And if you examine them and you see that lump protruding, you can say conclusively, this is pile hemorrhoids, and you don't need to panic that it could be anything more dangerous. I'll come back to some other bits, some other causes. So the symptoms would be pain, lump, bleeding. You can also have anal itching. So you have irritation around there. So you can have itching. It can also make you incontinent. So you soil yourself. So your sphincter not closing properly. You have poo coming out a little, so feces. So you have a bit of soiling. You can have a little bit of a discharge, like mucus. That slimy bit comes out as well. So you can have mucus discharge. Those are your classical symptoms, really. I mean, you can have complications where people get infection and all of that, and you have abscess formation, and then they can have other complications, systemic effects where they have fever and all of that. But for your common piles and by large, common symptoms would be lump, bleeding, pain. They will give a history of straining, and yes, we would say, okay, we examine you, you see a lump, we say that is pile.
Doc, we did a show many months ago, I believe, about when we did with rectal bleeding. Um,
Yes.
and it even confused me that when you were telling me that we are going to do this subject this here, I was thinking we did this before, but then because it's so similar. So my next question is, should we treat all rectal bleeding as being hemorrhoids or piles, or should we worry that it could be
Absolutely
something
not.
else?
Absolutely not. So rectal bleeding, if I were to get rectal bleeding in an elderly patient, for instance, we always think about bowel cancer and rule that out before we blame it on piles. So it has to do with the history. So the most dangerous part, or the most dangerous thing when it comes to rectal bleeding that we are worried about, always in the back of our mind, could this be cancer? Because rectal bleeding is a presentation of cancer. So
Right.
you don't want to blame all rectal bleeding to say, right, this is due to piles. But if you come with a classic history, there is a lump, you're young, I can feel the piles, I can see the piles, I would say, fine, this is piles, and there's no need for further testing. But in other cases, you can also have piles and have rectal bleeding coming from cancer. So let us not confuse that. But that would be unlikely in certain category of patient. As you know, cancer increases with age. And also, lots of time, this story can give it away. So if a patient comes to me and they're like, say, in their 20s and say, Doc, I've got bleeding, rectal bleeding, but I've had this last year and it went away, didn't come back again. And every time I strain, I get 2 or 3 occasions a year. I can safely say that sounds like piles, right? So I wouldn't worry about cancer, because if it's cancer, you will probably have some other presentation as time progresses. The cancer gets worse, and you have change in bowel habit, and you have weight loss and all of that. So based on that history. If it's a first time episode, I want to ensure that I'm not missing something else, and cancer will be the thing I'm looking for. And especially, I'll be more um, cognizant of that, or wary of that in elderly patients, because cancer risk increases with age. Or if there's a family history, somebody say, right, I have got a family history of cancer. But not, I mean, irrespective, you always have to have that at the back of your mind. However, if you examine the patient and you're convinced that, okay, this is piles, there is usually no need for investigation. If we're not sure, then there are things we can do. So we can put a camera in. So there are different sizes of cameras. You can do something called a short camera, like when you do a speculum examination, it's called a proctoscope. You put it in and you have a look and you can see the hemorrhoids. Lots of time you put your finger in a first-degree pile, for instance, and you put your finger in the anus, but because it's a blood vessel, when your finger goes in, it presses on the vessel and you don't feel it. You press down the vessel.
Right. So
So
it
you
move,
don't,
yeah, it moves. Yeah.
it empties. So you don't
Right.
feel it. And lots of
Okay.
time people would say, right, I'm bleeding, and you examine them and the examination is normal. But for you to see it, sometimes you have to put a short camera. The camera is probably as short as this.
Yeah.
And you put it in and then you circle around and you'll see it. So because remember, it's only about an inch or 2 inches. It's about two
Yes, that's
inches
yeah, yeah, yeah.
in that area that you can see. So you just need a short 2 inches, something to look at. If I'm worried, I think, okay, this can, then of course I will go deeper, and I will be. I will, not to confuse. So bleeding, so we can say hemorrhoids, we'll say cancer, and there's a condition called fissure, like an ulcer. So you can have an ulceration. So when you strain, sometimes you tear the back passage. So it's a tear in the back passage, and that is usually painful. And patients sometimes would not allow you to examine them. You can't put your finger into their anus. It's so painful. And the anus is tight. The sphincter have, go into spasm. And that is usually anal anal fissure. And then the other condition you can have, which you have bleeding. I'm just trying to look at bleeding from the local causes.
Right, yes.
Right? I mean, there are lots of other causes higher up you can have bleeding, but local causes, you can have something called a fistula. So the fistula is a hole, there's an opening on the outside of the anus, on the back passage, and that opening communicates by a tract into the bowel. Now that sometimes keep oozing blood, but blood and pus. So if somebody say to you that they have got on their underwear, they always have pus or blood coming out for months and months, I can safely say that is a fistula. It's an opening from the outside that is connected to the inner part of the bowel. We call it a fistula. And it oozes, it gets infected, and sometimes it forms an abscess. And then you have pus and you have discharge coming out from that little ooze. And then when you look at the back passage, you'll see a little hole. You'll see a little lumpy bit with a hole communicating with the inside through the side. So like there's a slight passage beyond your anal opening.
Yes, 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 yes,
There's
yes.
another opening. So that is called a fistula. So those are the common anal conditions that can give rise to anal pain.
Wow.
And bleeding.
So, yeah, my next question is then how do you manage the condition that you of hemorrhoids or what we call piles?
Yes, indeed. So, okay, so there are lots of things we want to do. So I said to you that the first thing I always advocate is non-conservative or lifestyle change, right? So if we know the cause of something, we always want to see if we can undo that so that we don't get it as a result. So if we can take away the cause. And I said to you, constipation, straining, low fat, not enough fiber in your diet. So you want to, first of all, try not to strain when you go to toilet. try to have regular bowel motions, ensure your diet consists of lots of fiber, drink enough water. So lots of fiber, drink enough water, do not strain. If you do have to strain, possibly get a laxative. Because in the management, there are two things. So if you have the pile comes out and it goes in back, it's not causing you too much of pain, we can then say, fine, do not strain. We give you some laxative. There are medication we can give you, and topical creams now we're talking about. So you have, we call this conservative management. So you have what we call conservative management and surgical management. So the conservative management will be all these creams and painkillers and that. So the creams, there are different types of creams. The creams will have some antiseptic on them. They may have some local anesthetic like painkillers. They may have some soothing agent, so soothe the area. And they may have some steroids in them, like Preparation H has got steroid in it. And as you know, steroid is an anti-inflammatory. So the intention there is to put some anti-inflammatory because the area is inflamed. I said the blood vessel is swollen and the tissue around it is swollen. So you want to give some medication to try to take away that inflammation. So that's your first line of treatment in mild hemorrhoids. And thankfully, most patients, I said that sometimes they have a straining episode and they pile flare up, or they have diarrhea, so you're going often to the toilet and they have a flare up of their piles. And majority of times, it resolves on their own. They take some laxative, they take some painkiller. And of course, usually it's painful, so you may need some pain relief. We would also advise if you go into a warm bath, so we call it sitz bath. So warm bath, you have a bowl and some warm salt water and you sit there. Sometimes it relieves the pain of the pile, or you sit in a bathtub, a warm bath. So those are things that can help with your pain, and they're conservative methods. There are now some intervention that you can do. Now, what are the interventions? So the blood vessel is swollen. What we could do, we could inject something. So in the blood, we can inject a liquid like oil into the blood vessel, and it causes the blood vessel to collapse, and it obliterates, it collapses and it pastes together. So sclerosant, we call it. So it causes sclerosis. So the blood vessel collapse and they squeeze together.
Right.
So that's a treatment. We call it sclerotherapy. Then you could take a rubber band. So I want to show you another image. So I'm going to share my screen. One sec. I just want to show you the rubber band technique. Maybe this here. This is another Google image. So just for, I don't know if you can see this clearly. Maybe, I don't know. Oops.
Yeah, let's double click on it. Yeah, it should open up top.
Is it?
Yeah.
No.
Yeah.
It's not, no, it wouldn't, I don't think
okay.
it would. Oh, sugar, I miss it.
Okay,
banding. Okay, fine, but okay, that's
no,
what
we
it
can
is.
search here for it. No, we got a few minutes, man. You got to bring it up.
Okay, so let me just find it then, because I was gonna
just type it in there. Yeah.
Yeah, so I'll put hemorrhoids banding, HAEMDING banding. Images. So this is Google search. Yeah. Okay, the same one here. I'm just trying to get it bigger. All right. Okay, this is better.
Yeah, right. That's fine. Yes.
Is it shared at the moment? Yes.
Yes. Yes.
So you see that you have an instrument, you clip it, and there's a rubber band here, and then you release the rubber band onto it.
Right.
So this is what they call banding.
Yes.
So the rubber band goes in there, and when it squeezes that, what it does, it locks off the blood supply, and the pile
eventually
falls off.
Collapses. Yeah.
Yes. Yes. So that is called banding. So I'll go through stop sharing that. Yeah. So you have, so you can inject something into the vessel. You could band it. And there are also different techniques where you can put electricity through it. It burns it. You can use cold therapy, cryotherapy we call it. So you can apply cold. You can apply heat. You could apply laser. They have different modalities of things you could do to shrink the blood vessel or collapse the blood vessel or burn the blood vessel. So those are some less invasive bits, but they are surgical, invasive. And then in the worst case scenario, you go and you do open surgery. Um, when it's an open surgery, you go and cut them out. You
Yeah,
cut
yeah.
them out, and usually, patients tend to do well if they're big and massive. The thing about these banding techniques and the other techniques, sometimes you have a higher recurrence rate. So even though you do that, it may come again or new ones might form. So sometimes if it's really bad and you're having lots of recurrence, you can go sometimes and have it all removed as in proper surgery. So that's your management and that's your piles in summary.
I got one
I
more
think
question. I got
yes,
one more question for you before we go
go
to
for
those
it.
other questions. I want to ask you quick. Um, Now, when all this blood, because I'm thinking, I probably look a bit perplexed while you were talking about that, but I'm thinking in my head, when these blood vessels collapse and there is all this removal of through banding and surgery and so on, functionality of the back passage or the rectum and so on, how is that affected in any way, in a great way?
No, usually no, because
Okay,
the back passage is rich in blood supply. And I told you these cushions, they have lots of blood, of arteries and veins,
okay,
and they're all linked together. So if I take away one part of it, the other parts would supply the rest of the area. So
okay,
it doesn't compromise that in any way. I mean, there are
brilliant.
complications when you do procedures. You can have infection, you can have scarring, and the back passage can get a bit tight. So those are, stenosis or something like that. So those are some of the complications. But the thing is, yeah, those blood vessels I'm now worried about. It's like when you have veins in your legs and you go and we can remove them surgically. We
Yes.
remove those veins because those veins are actually non-functional.
Hmm.
They're swollen. So likewise, the piles, the veins are swollen, they're damaged.
Okay.
So we want to
Okay.
get rid of them, and then you have enough to take care of the other functions.
Well, that's very good to know. So, well, thanks for all the information, Doc. Viewers, I'm now going to go to the questions from last week, and I hope that you've been sending your questions. Still a few minutes more to send in. Whatever question you want to send in, whether it's from on the topic we've discussed tonight or any other subject as it relates to health. So, first question is, Doc, Dr. Saw, is hallucination associated with dementia?
Definitely, and yes, that's a common thing in Alzheimer dementia. I talked about drugs used in dementia in terms of agitation and patients who get restless. Sometimes we use psychotic drugs. Also, patients hallucinate. So what we talk about, what is hallucination? Is a perception of something that is not there. So it's a perception of something that is not there. You're perceiving things that
Right.
are actually not there.
Yes,
So,
yes,
and
yes.
it can be different forms. You see things that are not there. You hear things. So that's called you have visual hallucination, auditory hallucination. So that's a thing we call hallucination. And there are psychotic symptoms, but we know in dementia, as I said, the function of the nervous system, the neurons, the cells, they're all malfunctioning because of that abnormal protein that get stuck there and disrupt the whole
Yeah.
architecture and the balance and the function. So yes, hallucination is a common symptom in dementia patient, albeit a little bit later on in the first part of dementia, you wouldn't hallucinate so much. You'd probably have memory impairment, and as I say, it's a progressive disease. As it goes down and it gets worse, hallucination is a common presentation.
Okay. Another question from about on dementia from last week. Doc, is there any physical pains in dementia, as in frontotemporal?
Um, the answer to that, if the question is there pain when you have dementia? Do you get pain as a result of the dementia? The answer is no. Generally, we don't have enough evidence to tell us that dementia itself, the condition itself, causes pain. But we know dementia patients, they experience pain like all of us. So if you have a mobility problem, arthritis, you will still experience pain. So even though the function of the brain. So the brain has to interpret pain, like when as a receptor sends signal to the brain, it tells us it's pain, and we have that high response. Dementia patient would still have that response, and there are times when those responses can be exaggerated or diminished. We don't know because there's an imbalance. The whole function is disturbed, but we know that they do experience pain from other causes, but we don't have enough evidence to tell us that the dementia itself is causing pain. So I would say most of the time, the condition itself is not causing them pain, but we have to be cognizant that these patients sometimes cannot relate pain. So they may have joint pains, for instance, but they cannot verbalize it. They cannot express it. We talk about even that frontotemporal dementia, where the patient has frontotemporal areas responsible for language. So if you cannot express that I'm in pain, it's difficult for your loved ones to know that you're in pain. So
Absolutely.
we always look for other things. We look, are they more agitated? Do they look, restless? You will see their grimace in the face. You may see some other thing you tend to look for, change of behavior. And then you can say, fine, maybe this person has experienced pain. And you look for causes. What are some of the other causes? Yeah. So that would be it.
All right. The next one here is, what about epilepsy?
Well, epilepsy is a lot about epilepsy. I mean, epilepsy is a huge topic because what is epilepsy? Is a tendency for seizures. So seizures, as we know, you can have generalized tonic-clonic where your body jerks, but they also have what we call focal seizure, absent seizure, different types of seizures. So in Guyanese, I mean, we say fits.
Right.
You
Yeah.
know
Yeah.
that term, right?
Yeah.
So there are seizures. So the tendency to seizure we call epilepsy, and is due to abnormal electrical activities in the brain. But I think let us do that as a topic, maybe next week or the other week. I think I will do epilepsy because epilepsy is a huge topic. We can talk all about triggers and some of the causes and how do we manage it. So I think that is huge. We'll spend half an hour doing that alone.
Brilliant. All right, great. Well, Doc, thanks to tonight's viewers. Thank you for joining us this evening. It was, as usual, a wonderful conversation, as always, with Dr. Saw, and he has a wealth of knowledge and experience, and I hope we can have him back here in Guyana sometime soon. So many people like Doc. So many people would like to come and see you and just to
And
meet you. And
yeah,
thank
send
you
the
so much for,
questions in. I'll shed some light.
yeah. Well, thank you so much for joining us, Dr. Saw. Is there anything you'd like to say before we close this evening?
No, thanks a lot again, Akash, and to the viewers. Thanks for tuning in, and good night, everyone.
All right, so viewers, thank you for joining us. We were coming to you live from TBN Studios. Join us again next week at 8 on every. We do the show every Tuesday at 8. So join us again next week, where we're gonna be doing another topic. And as Dr. Saw suggested, it may be epilepsy. So stay safe and stay healthy, everybody. Have a good evening. Bye bye.
Thank you.